Our next speaker is Dr. Benjamin Littenberg. Dr. Littenberg is the Henry and Carlene Tufo, I think I said that right, Professor of Medicine, Professor of Nursing, and Director of General Internal Medicine at the University of Vermont. He's a primary care internist and teaches both clinical medicine and clinical and translational research methods. Dr.
Thank you. Thanks. Well, thanks for having me. It turns out that Michigan is just like Vermont. I mean, not the economy or the environment or the people. But other than that, it's really very similar. Let's see. So, let's talk about managing chronic kidney disease in primary care. And so, the agenda for this talk is go a little bit over the scope of the problem. What is chronic kidney disease? A little review of the basics. What are the goals of care? And what can we actually do in primary care? Does it work? I'd like to show you some tools that are available to help your primary care practice do this better, louder, faster, easier. And then we'll have the discussion at the end. So in fact, the doors will be locked, and no one may leave until all the discussion is complete. Okay, I am at the University of Vermont. I'm also I'm the Chief Medical Officer of Patient Engagement Systems, which is a company that the university spun off. When this got invented, it turned out to work. The university said, we're not good at distributing inventions, so a company called Patient Engagement Systems. We did this in a clinical trial, and I'll tell you more about that. Okay, so what's the problem? The problem is chronic kidney disease is common, underdiagnosed, kills lots of people, costs a bundle, and is scary. It's scary enough to patients, but it is actually pretty scary to providers also. Many of us have been traumatized, scarred for life by second-year renal physiology course in medical school, and just go into a kind of fight or flight mode when presented with an abnormality of creatinine. So when I had to get into this, I had to go for therapy and take up Zen, and I'm starting to get over it, but it's scary. Okay, it turns out there's a lot of folks with chronic kidney disease, and the ones we know about are the stage 5 dialysis patients, and there's not quite 500,000 of them at any given time lately in America. That keeps going up. The stage 3s are the folks who have, they're in primary care for the most part. And the stage 1 and 2 people are for the most part undiagnosed. And they're very often in your practice and you don't even recognize them because of the quirks of the diagnostic criteria. But there's a lot of them and they turn out to be very important. Okay, so if you look at who gets it, let's see. This bar is 1990-ish, and this bar is 2005-ish, and it goes up with age. If you have diabetes, it goes up quite a bit, and we're seeing slight increases with the newer data. So it's becoming more prevalent over time, and interestingly, diabetes is becoming slightly less of a factor, hypertension becoming a little bit more of a factor. Okay, but it turns out that even in stage 4, which is really bad kidney disease, that's on the way towards dialysis, renal replacement therapy, 42% of the folks who were detected with stage 4 kidney disease said I am not aware that I have weak or failing kidneys. No doctor has ever told me that. Now, some of these people, this was a door-to-door survey, blood drawn in the right at home. Some of these people, frankly, don't get medical care at all, and some of them were under care, but it's not clear if the providers recognized the condition or if there was a failure to communicate or what. Only about 10% of people were aware in stage 3. Stage 3 is often on the provider's list of diagnoses, but there's no specific pills for it, and it's down in the weeds as far as the patient is concerned. Okay, life expectancy. It turns out that at any given age, of course, your life expectancy goes down. Notably, as your kidneys get worse, and worse, your life expectancy goes down to the point where, say, a 60-year-old with bad kidneys loses, it looks like about 5 years of life expectancy. They become pretty similar to a 65-year-old with good kidneys. So it's worth a lot of life expectancy. How's that graph going over?
What stage of chronic renal failure is that? 3 or 4?
The first one is essentially normal. The second one is bad filtration. So these aren't quite stages. It's the GFR less than 60, which means stage 3, 4, or 5. This one is protein, but no GFR abnormality. So that means a stage 1 or 2. It's a little bit flipped. And this is both. So it was a funny way of presenting it. I couldn't quite find one based on stage. Costs. So if you look at the costs of kidney disease, the per patient per year costs are $20,000 to $30,000 in Medicare, a little bit less in the younger age groups, and this is the all-in costs attributable to the disease. So $20,000 per patient per year is a lot of money out of the insurance budget. And it's going up over time. So the top line here is Medicare expenditures in billions of dollars per year. And as they say, 100 billion here and 100 billion there, and it starts to add up to real money. And this is just the part of it that's for CKD, and we're now pushing $4 billion a year on CKD, and it represents about 17% of Medicare spending is now for the couple of percent of patients who have end-stage renal disease, essentially. Okay, so it's a big problem for people, it's a big problem for payers, it's a big problem for the government health plans, and that doesn't even get into what it does to businesses and families and grandkids and all of that stuff. The human cost is huge. So, so what can we do in primary care? Well, we've got to identify these patients, engage them in their care. 42% knew that they had it. They're not engaged. Control their blood pressure. We've got to get them away from the toxins that make their kidney disease worse. That's something we can really get a handle on. We've got to coordinate with the specialists at the right moment, and at the right moment, we've got to start preparing the patient for renal replacement therapy, which is a big shock to the system. And not just them, but again, the family, and if they're employed and so forth. Is there a way to live a real life in end-stage renal disease? Yeah, but it ain't easy, and you got to prep for it. The complications, you have to look for them and manage them. And then, of course, in primary care, you've got to do all the other stuff. Hypertension, diabetes, depression, sprained ankles, the whole vaccinations, the whole thing has to be managed. So you can't do this by the seat of your pants. you need a system because it's a big, complicated problem, and you don't see it every day. Like a nephrologist gets up in the morning and deals with kidneys all day and then goes home. And they get real good at kidneys. As primary care docs, we don't have that kind of intensive exposure so that we know and have at the tip of our fingers exactly the right thing to do every time. Okay, so how do you identify patients? Well, it's very simple. Here's the serum creatinine and the urine albumin to creatinine ratio, sometimes called the urine protein, and calculate the estimated glomerular filtration rate. Now, I wasn't always able to do this in my head. Okay, so obviously you need help in doing that. And in the last couple of years, the labs have started reporting estimated GFR along with the serum creatinine. The important thing to remember is that the serum creatinine is a totally misleading number. It is, if you wanted to design a lab test to confuse you, you might very well come up with the creatinine, because it's related to the thing of interest as 1 over x, meaning the hyperbola, that, you know, it's the piano shape, so that doubling from 1 to 2 is totally different animal than doubling from 3 to 6, say. Those are just, and that's hard to do in your head. People we're kind of okay at straight line transformations. We're really lousy at curved transformations as people. So you need something like a computer to do that for you. Okay, stages 1 to 3, how do you treat them? Blood pressure control. It's the single most important factor, and we push pretty hard. You really want to see the systolics as low as you can without them falling over. It is hard to get the systolics below 125, but that's really where you ought to be aiming for. You want to use an ACE inhibitor or an ARB drug to slow proteinuria and also to deal with coronary vascular disease. You want to tighten up the diabetes control as much as possible. You want to manage the cholesterol. These are, whether they have diabetes or not, whether they have known coronary vascular disease or not, these are high-risk equivalent, coronary equivalent patients. Yes, sir. And again, avoiding the toxins and seeing if you can't get them to not become couch potatoes, which is, as you know, bad for whatever ails you. Okay, then you go into stage 4 and 5, which is when you're really, I think the technical term for stage 4 in kidney disease is circling the drain. These people are in big trouble, and you want to have a nephrology consult for pre-renal replacement therapy planning. I know there's a couple of nephrologists in the room. I hope they'll forgive me for saying there is a mysterious point in time when the patient is best referred to nephrology. And my experience is it's either too soon or too late. That, you know, if you don't want to send people who don't need nephrology services, there's a shortage of nephrologists, and, you know, they can't do much that you can't do in early disease, you know, unless there's a complication or a diagnostic mystery, but for routine cases, PCPs can handle them. If you send them too late, though, there's this awful scramble to get the renal replacement therapy started on time. And in fact, if you do get them in at the right moment, you can actually manage the transition to replacement, typically dialysis, without ever admitting them to the hospital. And of course, hospitals are expensive, nasty, and dangerous. So a good nephrology team can do that if you get them at the right time. But it's hard to know. So you have to have some sense of the trajectory of their disease. Typically, it's somewhere in early stage 4 or late stage 3 is the right place, but there's not a lot of guidance on that. In stage 4 is when you start to see anemia become a significant problem, and Donna's going to talk more about how to manage that as a complication. It's a big deal. Nutritional support. We're not 100% sure exactly how to manage the diet in diabetes. There's a lot of debate, but certainly we are aware of the role of sodium, potassium, and calcium, and phosphorus, and protein. It gets to be complicated, and the patients need a lot of support. Exercise, medications, as they start to lose their ability to filter, their medicines are going to build up, at least those that are renally excreted, and there's a pile of them that need to be adjusted so that we don't inadvertently poison the patients with the drugs that they've been on for years. And of course, there's the metabolic complications and the emotional complications. I did have a big fella in my office, he fooled me. He's a 6'4", former linebacker who's gone to seed, a big, massive guy who blocks out the light, who I'd been working on his diabetes with him for years, and he was in denial a lot and playing fast and loose, but his kidneys were starting to go, and I had him on the exam table, sitting on the edge of the exam, and I said, look, I got bad news. Your latest kidney tests they're starting to decline, and I'm worried about kidney failure. And he said, Doc, I'm going into kidney, he was like, he went right out, boom. And I'm not a little wallflower, but I couldn't hold him up. And we had to get 3 staff in to help me. We got him to the ground. I remember one nurse on each of his big tree trunk legs, holding his legs up to wake the guy up. But the emotional complications of diabetes can be acute, and of kidney disease can be acute and sudden. He didn't take the diagnosis of diabetes badly at all, but kidneys really scared him. Okay, how are we supposed to manage this? Well, there's guidelines. There's now actually slightly competing guidelines from 2 groups, KDOQI and KDIGO. They're mostly the same. They're lengthy and complicated. The National Kidney Foundation's, either one, I think I counted the KDOQI rules, 417 specific if-then statements just for diagnosis and staging. That's not even before you get to treatment and management. Early stage CKD, often unrecognized. Patients with creatinines that look like they're kind of normal, excepting they're not really normal for that age and sex, or they are normal, but there's urine protein or other evidence of renal damage that you just don't think of as kidney disease, and therefore you never put it on the problem list. There's a lot of that, and therefore lost opportunities to prevent progression. And testing and referring are often just non-existent. In fact, when we've looked at several practices, we've scanned their diagnosis list, and you find, say, in a large practice, you find 1,000 patients with diagnosed CKD. We go in and check the labs, and we find another 850, 900 patients with CKD that were not on a problem list or on a bill in the last couple of years. Mostly mild, a couple of advanced cases, missing stage 4 disease, kind of scary. Okay, keeping track of results is difficult. Doctors love flow sheets, they hate to keep them up. Patients use different laboratories, and getting them coordinated is a problem. The medical record could possibly someday help with this. Currently, it's not very good at that. Interpreting the results is difficult. CKD is among the more complex problems that a primary care doc is liable to come across. Patients get lost to follow-up. Dr. Bruin's already talked about, veterinarians and dentists and garage mechanics have figured out how to keep us engaged in the care of those things, but physicians not so good. And doctors and nurses are trained primarily to look at individual patients, the patient who's in front of us at this time. So Ms. Voss was talking about putting together the team that looks at a panel of patients. And So that's an attempt to get this population view. Still early days for that, but it's good stuff. Perhaps most importantly is the patients don't know what to do. Even the ones who know that they have a problem don't really get it about how they can help manage it their part themselves and take part in prevention. Okay, so what can PCPs do? Screen and diagnose aggressive blood pressure and cholesterol management, medication errors, the bane of our existence, the timing of specialty consultation, the transition to dialysis to avoid hospitalization, and anemia management. Okay, so now I want to talk about, having set the table for the goals of care, I want to talk about some specific systems to make it better. We've got two ailing parties. The provider and the patient are both in trouble here. And frankly, neither one of them gets it, that they're in trouble in a lot of ways. PCPs can do a great job with these patients if they know what to do, they have a system, and they develop relationships with these patients. The continuity of care, the thing that primary care, the secret sauce of primary care, it turns out is the thing that makes people better. If you need a heart surgeon, you need one real bad. If you need a nephrologist, you need one real bad. But the primary care doc is the long-term glue that makes people feel better, keeps them out of trouble, and in study after study, the more primary care you get, the less likely you are to show up in a hospital, in an emergency room, or an operating room, to have a big hospital bill and so forth. So and it's the relationships with the patients that matters. So the PCPs can do a good job if they have those three things. The patients can get good care if they are activated to take action, if they're in the loop, if they feel like they're part of their care and they have good relations with the providers. So what can we do to enhance all of this? The triple aim, we already heard some about this. So we want to improve the population, make the patient experience better, and control costs. And so for kidney disease, if we control costs, that means managing to guidelines for the most part. To improve the health, we've got to identify and intervene earlier, and enhancing the patient care experience, that is really about the relationships. Okay, so principles of design. Use every resource at its highest level. Do not hire physicians and pay them six-figure salaries to fill out forms and talk to clerks at insurance companies. This is not a good use of the resource. In fact, try not to have anybody talk to the insurance companies if possible. Use systems that identify who needs care first when they need it. Get the patients motivated to self-identify what they need and to come on in. Save the staff energy for exceptions. Routine stuff should happen with nobody, if possible, lifting a finger. But even if they need to do something, it shouldn't require much effort. They shouldn't have to invent it every time. It's the exceptions, the patients who don't fit the routine, is where we ought to be putting our energy. So the Pareto law of 80-20 is actually a good thing in this setting. You want 20% of your patients to be consuming 80% of your resources, and the other 80% of your patients to be sailing through because we know what to do with them automatically, and they don't require an awful lot of energy. And use providers for what providers do best: face-to-face assessment and decision-making. So if it's not face-to-face assessment and decision-making, you might find a better way to deliver that service than to have your docs doing it. Okay, so we already heard a little bit about registries, and yes, EMRs are not registries, thank you, that's a really big deal, because EMRs have been sold, and oh, by the way, it's also your registry, but registry functions are quite different. It's not clear why no EMRs are currently designed to be registries. They probably could be, but none of them are, and you're looking for gold in a silver mine there. So we need to integrate data from multiple sources, notably multiple laboratories for people who, well, depending on where you live. Feedback to providers about individual patients with value-added reports. The report that says creatinine 1.3 is just not useful. ACR 47, not useful. It's got to be put in context, and it's got to be more than the normal range. We got to have feedback to patients, and we've also got to be able to look at the population level. Well, this is the way we handle chronic infections. This is how tuberculosis is handled and sexually transmitted diseases and cancer registries. Why not do it for CKD? And engaging the patients, so the feedback to patients part is really critical there. Okay, we were looking for something that was low cost per case, low technology investment at the practice. In other words, we did not think that primary care practices were going to buy more computers. If they had an EMR, great. If they didn't have an EMR, great also. Little change in the practice flow. We already heard about how reluctant PCPs are to take 2 or 4 or 8 hours off to retool their practice for a new process. Little disruption of the patient-provider relationship, because that's the secret sauce. Multiple data sources, and high face validity, accuracy. If this thing complains about a patient where the complaint is not warranted, or if this system suggests something that for a patient who is not really your patient, the provider starts tuning out the rest of the signals from that system pretty much instantly, and the whole system becomes ineffective. So you've got to make sure that anything the system tells the provider is accurate. Okay, so we wanted something with outreach, clinical outreach, flow sheets updated after every lab result, reminders to the providers, reminders to the patients, alert letters to the patients, and population reports to the providers. Here's how your population is doing. And we can share that with case managers as well. All the products that I'm talking about are based on national guidelines. Let's see. So here's how it works. You have a bunch of clinical laboratories, and they are provider orders a lab test, the patient goes to the lab happens on say a Monday morning. In the evening, we get the results in a data transfer from the clinical lab. They go to our computer, which is buried in a secret, secure location that I can't tell you where it is, but Vice President Cheney knows where it is. I'll just say that. He used to hang out there. So, and then we produce reports that go to the primary care provider, either through the EMR or a portal or fax. The patient, we typically like to use first-class mail. Letters from your provider, first-class mail, actually probably have more impact than email or text or automated phone calls. But we can do it a number of different ways. And disease management folks can get the reports also. So typically, if your lab was done Monday, we get the results Monday night, and these are all available and delivered before start of business on Tuesday morning. Okay, so here's an example. Here's a CKD patient roster. So it's a blow-up. And each line, we got stage 5, stage 4, stage 3, so forth. So, here's a patient's name, date of birth, their estimated GFR and the date, their albumin. Yeah, this is a stage 3 patient. Got plenty of protein. Also, their hemoglobin and their LDL cholesterol, which are key decision makers. And they're all listed there. along with some basic advice from the guidelines. For this stage, we check these tests quarterly. For that stage, it's every 6 months. And if a patient has got a dagger next to their name, their date, that means it's overdue. And it's for your quality improvement team, and it's also for the competitive docs. It comes with a little, and they're all competitive, it comes with a little report card on top. Here's how you're doing. Here's how the other docs in your practices are doing. Here's how the other docs across the country are doing. Here's a letter to a patient. So it comes on letterhead, sent on behalf of, we use Dr. Osler's practice, William Osler. Unfortunately, he does a very bad job, it turns out. Here's a patient with an LDL cholesterol of 156. We should be working on a plan. If you haven't heard from us recently, give us a call. We got to get back, and this is not good. Here's an overdue reminder. Again, on letterhead, we send you a letter if you're overdue. You're currently overdue for these tests. Bloop, bloop, bloop. Please call us so that we can get you a lab slip or whatever. Here's a flow sheet on a single patient. So we've got the patient identifiers on top, and then renal function, which is GFR over time, proteinuria, anemia, lipid profile, some graphics, some, here, results suggest iron deficiency anemia, consider iron therapy. If iron is not effective or not tolerated, consider iron sucrose or amoxicillin. This comes, as I say, the day after a lab is reported. So it's real-time patient-level analytics. They're easy to use flow charts. There's a gap analysis, if you will, that's guideline-driven. We also give provider-level dashboards, and if there's quality reporting, we can do the roll-ups to tell you how many patients you have who meet your HEDIS criteria and that sort of thing. Okay, so does it work? Well, there's 5 things it might work on. Case identification, patient and provider acceptance, process improvement, outcomes improvement, and financial improvement. So these are the 5 areas that we hoped it would work. We've got mostly evidence on the diabetes model, because the CKD one hasn't been around as long. But we do have some evidence on CKD in clinical use. So I'm going to show you some of that evidence. Okay, automatic case detection. It creates the opportunities for personalized communications. We think patients benefit from early stage detection and so forth. For, in certain cases, identifying people as CKD means you actually can get a little more revenue for your practice if you're on, say, a Medicare HMO plan. Here's a situation, well, I told you a little bit about this. This is a customer out in California who said, oh, we've got it under control. We have 632 people with chronic kidney disease. We're an HMO, we track it carefully because it's worth quite a lot of money every month to us, every diagnosis we find. And we said, great, and we found their 632 and another 565 they didn't know about. Because they knew about the ones that had received a bill for CKD. And they did not know about the ones where there was no bill. And we knew about the ones that had abnormal laboratories, which is essentially the definition of CKD. And that difference is a lot. So those 565 patients were a revenue loss for the plan, but they were a care loss for the patient and a failure to intervene for the practices. Okay, how does this thing go over? Well, in the clinical trial, 98.1% of the patients who we asked to participate agreed. In commercial use, it's a little bit higher. Essentially, 1% of the patients call back and say, no, take me out. It is a passive consent situation, so, but we just turned on several hundred patients in a practice in Vermont last week, and we got 0 complaints to us or the practice. Patients like it. The providers say, look, this is valuable, it's easy to use, it improves my relationships, it allows for smarter decisions. They see that the patients appreciate it. Do they all jump up and down and love it? No, providers don't like anything. I don't know if you've noticed, but doctors essentially don't like anything, but they're willing to tolerate this. And some of them actually are really very happy about it. Here's some patient quotes. These are real patients, really said this. We had a guy from the business school do basically a marketing thing. He called up a bunch of our patients and it said things like, it lets me know when I have to go to do lab tests and stuff. It got me thinking about my priorities. I realized I had to take care of myself first. The most useful part was that doc was thinking of me. Wow, this is the first time the practice reached out to me. I didn't have to go, climbing through the phone tree to get a hold of them. And my favorite, my wife handed the letter to me and said, you gotta go to the doc. As you know, married men live longer than single men, probably because their wives make them take better care of themselves. I don't know. Okay, randomized trial, 7,400 people, 64 practices. These were all adults with confirmed diabetes, mostly type 2. I'm sure there were a couple of % of them had type 1, as always, but we didn't know who was who. And this is the improvement on-time testing. And in fact, strangely, the A1Cs were already pretty good before we started, so we only picked up 17%, about 40% for cholesterol and creatinine, and 74% improvement for urine protein. Improvement in key measures. So again, these are the testing before and after in this IPA. Cholesterol testing was 52% on time, went up to 78. By the way, this is on time for the American Diabetes Association, which is stricter than HEDIS. HEDIS says just once a year, but for cholesterol, for instance, if it's out of control, you're supposed to check, just to make an adjustment and check it again in several months. So these numbers are a little lower than the HEDIS numbers. Nephropathy testing, typically only a few % of patients are actually getting the right test. What we find is they're getting urine protein tests without a urine creatinine, and nobody recognizes that that's the wrong test. It's supposed to be the ratio, that if you don't divide the amount of protein by the amount of creatinine to adjust for body size and metabolism and so forth, you're getting an uninterpretable number. That unfortunately tends to be in about the same range and has similar looking units. It comes out in milligrams per DL instead of micrograms per milligram. And most people don't look at the units. So in some of these cases, what we've done is gone in and changed the order sheets and got the rates to go up. And I'm on a little bit of a crusade to get every lab in America to stop doing isolated urine proteins, which have very little clinical utility. Blood sugar control went from 43% to 76%, cholesterol from 25 to 49. We saw an increase in HDL on this thing, possibly the only intervention ever demonstrated to do that. Oh, here it is. So 1,000 patients, I had the data for 19 months when I drew the slide. A1C fell 2%. Now that's not from 9 to 7, that's a relative change. So if it was 10, it went to 9.8 something. But a 2% drop in cholesterol, a 0.8%, almost a 1% increase in HDL, and LDL and trig went down. These are all statistically significant. Okay, the NIH study, diabetes again, inpatient utilization fell 15%, emergency room 28%. I'm pretty sure that this is how we got this. That once someone goes to the emergency room, there is a large random factor about whether they will get admitted. That somebody will notice something and decide to admit them. I'm not talking about major trauma or acute MI. I'm talking about an out-of-control chronic disease patient shows up in the emergency room. It's almost unpredictable whether they will get admitted. If you keep them out of the emergency room, they won't get admitted. And the charges are similar. So we saw better outcomes and lower utilization. Okay, there's been a lot of talk about bending the cost curve. As far as I know, this is the only bent cost curve in captivity. It's one HMO that had a lot of patients in the trial, and we got their entire paid claims experience going back 4 years, as far back as 4 years on some patients. And we tracked the randomized groups. So this was the active group in the solid blue. This is the treated group in the, the control group in the dotted blue. And what you can see is that they're pretty close. There is a little bit of divergence in the year before. I don't know why, but really random. And then the group that had the system in the first year, their spending stabilized and bent down and continued to go down for 2, 3, and 4 years. The average savings between the two groups is $2,400 per year over the 4 years. And that's net of the costs of delivering the service. So that's savings to the plan, to the providers if they have a share in cost savings, to Medicare, to whomever. Okay, so what's going on? How does this work? Communicating with patients, engaging them improves health. Mechanism not entirely known, but it's been shown over and over again. They certainly get more testing. We looked at their med lists. They are not getting more meds. This was disappointing to me. The folks with diabetes out of control were not getting switched to insulin more often. And it's that inertia that Sue talked about. Primary care docs and patients hate to advance chronic disease care, and they manage to convince each other that that's okay. It's not okay. This system probably doesn't fix that, but it allows us to at least see when it's happening and try some other interventions. They get more planned care, less emergency care. They have fewer ER visits and hospital stays. We broke it down by major diagnostic category. We saw fewer vascular admissions. We saw fewer coronary admissions. We saw fewer cancer admissions. We saw fewer trauma admissions. We saw fewer of everything excepting OB. So I'm glad that our intervention did not interfere with fertility. Total costs go down by over $2,400. Okay, so I'm coming to the end of my prepared remarks. CKD, it's common, expensive, and deadly. The current care is suboptimal. Primary care providers can do a great job taking care of these patients, but they gotta have a system and they gotta have some sort of patient engagement to help with that. And that's my name, and I will refrain from asking for questions, but I think we're gonna take a break now. And so we could talk at the break without really violating the rules. That would be okay by me. Jeff?
Thank you.